Okay, let's turn our attention to the blood supply to the upper limb, and this we can go through fairly quickly. Not a terribly high yield topic. The blood supply to the upper limb comes initially from the subclavian artery. As the subclavian artery passes through the axilla, it changes its name and it's called the axillary artery. When it leaves the axilla and enters the arm, it's called the brachial artery. As the brachial artery reaches the elbow, just after it crosses the elbow, it divides into a radial and an ulnar artery, and then both radial and ulnar arteries cross the wrist and enter the hand. So, a couple of important points to keep in mind. As the axillary artery is coming through the axilla, remember it's sitting right in the middle of the three cords of the brachial plexus. Right? Because remember, the cords were named according to their relationship to the axillary artery. So it's sitting right in the middle of the three cords, and it's bound together with those three cords by a tough connective tissue sheath, called the axillary sheath, which means that if you develop a bulge or an aneurysm of the axillary artery, and that sometimes happens particularly in athletes, like pitchers who are fairly traumatic to their shoulder region, the movements that a pitcher has to make, you can develop an aneurysm of the axillary artery. And because the three cords of the brachial plexus are being held right up against the axillary artery by the axillary sheath, the axillary artery aneurysm can cause compression of any one of those cords and thereby result in neurological findings. So oftentimes, the symptoms associated with an axillary artery aneurysm are actually neurological symptoms because of the compression of the cords of the brachial plexus. Further distally, the thing to keep in mind is that the the brachial artery, as it's approaching the elbow, is sitting immediately medial to the tendon of the biceps and immediately lateral to the median nerve. So that's the region where you're auscultating the brachial artery when you're taking blood pressure, listening for the bruit, the brachial artery bruit. And so remember, the location of that artery is just medial to the tendon of the biceps. And because that artery is sitting immediately lateral to the median nerve, and we already talked about how a supracondylar fracture at this level can affect the median nerve, that same supracondylar fracture can affect or can occlude the brachial artery before it has divided into radial and ulnar. And so an occlusion of the brachial artery here can dramatically affect blood supply to the entire distal limb, forearm and hand. So in a supracondylar fracture presentation, the first thing you want to do with that patient is feel for distal pulses, feel for radial and ulnar pulses to make sure that blood flow has not been compromised, because that's going to be the more urgent issue. If those forearm muscles are deprived of blood flow for more than a few hours, they're going to start developing ischemic contracture, and that can become debilitating pretty quickly. So you need to check for the integrity of the brachial artery. And then the last point I would make is notice that the radial and ulnar arteries both enter the hand, and they anastomose with one another by way of these two arches, or what are called palmar arches, superficial and deep palmar arches. Those are both anastomoses between radial and ulnar arteries. And because of those anastomoses, in most people, the hand can survive very nicely with only one of those arteries. So if you were to occlude the radial artery, the ulnar artery can supply the entire hand, or vice versa. And that's why it's acceptable to harvest the radial artery. It's being done fairly routinely now. The radial artery is often harvested as a graft for coronary artery bypass, because you can get by without a radial artery as long as you have those collaterals. But that means that before you can do anything that would endanger either the radial or the ulnar artery, whether it be harvesting it for a graft or something as simple as doing an arterial stick to take an arterial blood gas sample, which of course risks thrombosing the artery, before you do that, you want to make sure that the hand really can survive on either artery. In other words, you want to make sure that these collateral pathways are adequate in that patient, because they're not in every patient. And so the way you can do that is you can compress both of those arteries on the patient, right? Just compress the radial and compress the ulnar. Just use 2 fingers and compress them. While you're compressing the arteries, ask the patient to make a tight fist to squeeze the blood out of their palmar capillary beds, and then have them open the hand. Because you've compressed both of those arteries, the entire hand will be blanched. If you then release just one artery, if you just release the ulnar artery, leaving the radial artery compressed, just release the ulnar artery, in a normal patient, the entire hand should pink up pretty quickly, which would indicate that the hand can survive on just the ulnar artery. Once you've seen that, you know that it's safe to take the radial artery or to risk the radial artery. But if when you release just the ulnar artery, if only part of the hand pinks up and the rest of the hand doesn't, then you know that the collaterals in that patient are not very good, and therefore if you were to sacrifice the radial artery, you will have sacrificed that patient's hand. So it's important to do that test. That's called the Allen test. The Allen test for testing for the integrity of the collateral flow between radial and ulnar artery in the hand. Okay, that's all we'll say about the arterial supply. Let's turn to a couple of issues of skeletal injury. We'll start with the shoulder. So, looking at the shoulder, the most common dislocation in the body is a shoulder dislocation. Shoulder dislocation. And the reason the shoulder dislocates so often is because it's built in a way that's actually very unstable. And it's built to be unstable because the intention of the shoulder is to be very mobile, because the whole purpose of the shoulder is to have a wide range of motion for the upper limb so you can position your hand in space. So you want lots of mobility. So to have mobility, you have to give up stability. So we have an unstable shoulder. And what makes the shoulder so unstable is that even though we call it a ball and socket joint, certainly the humeral head looks like a ball, but the glenoid fossa is hardly what I would call a socket. It's very small and it's very flat. So you actually have a big ball articulating with a small flat surface. That's unstable. So if the bony construction of the shoulder is not stable, that means there must be something else that is maintaining stability of the shoulder. Otherwise, it would always dislocate, right? Most of the time it doesn't. So what's holding the shoulder together? And for the most part, it's the tendons that cross the shoulder joint, the tendons that collectively are called the rotator cuff tendons. There are 4 of them. Now on this diagram, we can see one of them, the supraspinatus. That's one of the rotator cuff. It crosses over the top of the joint, and then its tendon will blend in with the joint capsule, reinforcing the top of the joint and adding stability. But what we really want to be able to do is see all 4 of the rotator cuff tendons at the same time. So the way we can do that is we'll stand over here laterally, look into the shoulder from the lateral side, remove the humerus, so we're looking into the shoulder joint and we're looking at that surface right there. That's what we'll see on the next slide. Okay, we're looking from the lateral side. There's the glenoid fossa. The humeral head used to be sitting right there. Okay, and we see the shoulder joint capsule surrounding that. And we see the rotator cuff tendons. There's the one we looked at before. There's the supraspinatus coming over the top of the joint, reinforcing the capsule from the top. On the front side of the joint, we have the subscapularis, reinforcing the front of the joint. On the back side of the joint, we have the infraspinatus and the teres minor tendons, reinforcing the back of the joint capsule. So those are our 4 tendons, supraspinatus, infraspinatus, teres minor, and subscapularis. It's called SITS, S-I-T-S. And you see that reinforces the back, the top, and the front of the joint. But we have nothing reinforcing the bottom of the joint. And not only is there no tendon reinforcing the bottom of the joint capsule, if we go back and look at the previous slide, we see that the joint capsule itself is very slack inferiorly and is designed that way in order to provide lots of mobility, lots of range of motion. So you have a slack capsule inferiorly, and you have no reinforcing tendon inferiorly. And so that means that if this humeral head is going to dislocate out of this joint, it's most likely going to dislocate inferiorly, where the capsule is the weakest. And that, in fact, is the case. Typically, when the humeral head dislocates out of the shoulder joint, it dislocates inferiorly. That leads to the question of what kind of force would cause that to happen. Well, if you want the humeral head to go inferiorly, in other words, the proximal end of the humerus to go inferiorly, you can accomplish that by forcing the distal end of the humerus to go superiorly. Sort of like a lever. If you think of a seesaw, if you push one end up, the other end goes down. So if you take the distal end of the humerus, in other words, the elbow end, and push it up, the proximal end goes down. So if the patient were to have a fall onto the laterally outstretched arm where the elbow strikes the ground and gets forced upward, that forces the humeral head downward, and it can dislocate out of the joint. So that can happen. But we need to explain what is a common clinical finding. The overwhelming majority of shoulder dislocations present clinically as anterior dislocations. When the patient presents, it's in the emergency room with a shoulder dislocation, typically that humeral head is sitting over here in that position. That's where the humeral head is typically seen, anterior to the joint, sitting right under the coracoid process. So how could that be? If it's dislocating inferiorly, why is it anterior? And the answer is, it is anterior, but it didn't get there by exiting anteriorly. We just said it exits inferiorly, but this is what happens. With that forcible abduction, the humeral head goes downward in that direction. When you are abducting, you're always externally rotating at the same time. You cannot fully abduct without external rotation. External rotation causes the humeral head to go forward in that direction. So the humeral head goes down and forward. And then, because of the trauma to the joint, sort of as a protective mechanism, the large muscle crossing the joint, the deltoid, spasms and pulls the humerus upward. So if you pull the humerus upward from that position, you're now over here. So the humeral head gets here not by going that way, but by going that way. And the reason we want to know that is that that tells us that if you want to reduce that dislocation, if you want to get that humeral head back into the glenoid, you can't accomplish it by pushing it back that way. The joint capsule is in the way. It's not going to go back. You want it to get back in there, it has to go back the same way it came out. So you go down, back, and up. So in other words, you apply traction, internal rotation, and then release, and that same deltoid muscle will pull it back up that way. So you reduce it by going down, back, and up, because you dislocated it by going down, forward, and up. Now, the last point to be made goes back to something we talked about earlier. We said that when you have a shoulder dislocation, two nerves are endangered. One is the axillary, the other is the radial. Well, here's where the axillary nerve is sitting. Remember, we said it sits right next to the surgical neck of the humerus. This is the surgical neck. So that's why a surgical neck fracture endangers the axillary nerve. But you see, it's also directly under the shoulder joint. So if the humeral head displaces inferiorly, the axillary nerve can get stretched by that humeral head. So that's why it's in danger. The radial nerve, remember the radial nerve comes from the axilla and heads toward that spiral groove. So it's coming down this way, and then it gets sort of held in place against the humerus by the triceps muscle as it goes through the spiral groove. And since it's being held in place by the triceps, if the humerus heads downward, that means the triceps is being pulled downward, which means the radial nerve is being pulled downward. And so the downward displacement of the humerus puts traction on the radial nerve. So because the axillary and radial nerves are both sitting right below the shoulder, both of them are endangered by the downward displacement of the humerus during a glenohumeral dislocation. Okay? Let's now take a look at the wrist and a couple of important injuries at the wrist. When we look at the architecture of the wrist, or the articulation between the hand and the forearm, we see that the major articulation between the hand and the forearm is actually between these two carpal bones and the radius. We see that the ulna is almost completely uninvolved. The radius is the major bone at the wrist, and it articulates with the scaphoid and the lunate. The important point about that is that when you are transferring force across the wrist, in other words, transferring force from the hand to the forearm, which is what happens when you fall on the outstretched hand, right? You're falling on the outstretched hand, the ground hits the hand, the force has to get transmitted from the hand to the forearm. That force is all getting transmitted across those two bones to that bone. And so the two bones, the two carpal bones that are bearing most of that force are these two. So the two carpal bones most likely to be injured are these two, scaphoid and lunate. And as it turns out, the injuries that those two bones suffer are different. Lunates tend to dislocate, scaphoids tend to fracture. And it's the architecture of those bones that cause that. And let's take a look at why that is. Let's look at the lunate first. If we look at this in cross-section, okay, here's the carpal tunnel. There's the lunate, one of the bones of the carpus. There's the carpal tunnel, there's the flexor retinaculum. Remember, the carpal tunnel contains the median nerve and 9 tendons. But notice that the lunate is sort of a wedge-shaped bone, and it's narrower posteriorly than it is anteriorly. So when you hyperextend your wrist, which is what can happen when you fall on your outstretched hand, that tends to squeeze the lunate out of position, and because of its wedge shape, it tends to get squeezed forward in that direction. So when the lunate gets dislocated, it typically dislocates anteriorly, which means it's dislocating into the carpal tunnel, and it's now occupying space of the carpal tunnel. Well, the carpal tunnel doesn't have a lot of extra space to spare. Remember, it's filled with tendons and a nerve. And so the structure that's in the carpal tunnel that's most susceptible to compression when that happens is the median nerve. So dislocation of the lunate is typically an anterior dislocation, which endangers the median nerve in the carpal tunnel. And when we look at this slide again, where the median nerve has been drawn in its correct position, you see that the median nerve crosses right in front of the carpal bone, so that anterior dislocation certainly can cause compression of the median nerve. And we already know what happens when you compress the median nerve in the carpal tunnel. We've talked about that. With regard to the scaphoid, scaphoids tend to fracture. And again, it's the architecture of the bone. It's not particularly obvious from this particular projection, but the scaphoid is more or less an hourglass-shaped bone. It's wide distally, it's wide proximally, and it has kind of a narrow waist, like an hourglass. So when you transfer force across the scaphoid, the most likely fracture site is across the waist. So right across there is the most common site for a scaphoid fracture. The reason that's really important is that the blood supply to the scaphoid almost entirely enters the scaphoid at its distal end. All of the vessels that supply the scaphoid enter the scaphoid at the distal head of the scaphoid, which means that the proximal head of the scaphoid gets its blood supply by way of branches of these vessels that have to traverse the scaphoid to get there. So that if you fracture across here, you're separating the proximal head of the scaphoid from its blood supply, which means that that puts the proximal head at risk of avascular necrosis. And so that's a really important clinical sequelae you need to be aware of. Proximal head of the scaphoid is subject to avascular necrosis when there is a scaphoid fracture. And it's because of that blood supply issue that scaphoid fractures tend to heal very slowly or not at all, because the quality of bone healing is directly related to the quality of blood supply. You compromise the blood supply, you compromise bone healing. Okay, so that's the story of the wrist. So what we wanted to accomplish in the upper limb was to go over the neuromuscular components, talk about the upper limb nerve injuries, which we've done, a bit about the arterial supply, and finally the injuries to the shoulder and the wrist. Dislocation at the shoulder, lunate dislocation at the wrist, and scaphoid fracture at the wrist.